Hello dear friends, how are you doing today? I hope you are doing well. Welcome to a new question about dermatology. Which one of the following antibiotics is most associated with the development of Stevens-Johnson syndrome? A. Cotrimoxazole, B. Ethambutol, C. Chloramphenicol, D. Ciprofloxacin, and E. Gentamicin. Okay, this question is asking about the antibiotic which is most associated with development of Stevens-Johnson syndrome. Among this antibiotic, cotrimoxazole is the most associated with development of Stevens-Johnson syndrome. Explanation: Stevens-Johnson syndrome. Stevens-Johnson syndrome, or SJS, is a rare, severe, and potentially life-threatening hypersensitivity reaction that affects the skin and mucous membranes and is almost always caused by a drug reaction. And this is important. It's almost always caused by a drug reaction. SJS is considered a part of spectrum with toxic epidermal necrolysis, or TEN. If less than 10% of body surface area or detachment is seen, then it is Stevens-Johnson syndrome. But if 10 to 30% of body surface area detachment is seen, we call it SJS, Stevens-Johnson syndrome, and toxic epidermal necrolysis overlap. But if the patient, more than 30% of body surface area detachment is present, then we call it toxic epidermal necrolysis. And SJS is the detachment of body surface areas of less than 10%, and in toxic epidermal necrolysis, more than 30% of body surface area detachment is present. Features of Stevens-Johnson syndrome and toxic epidermal necrolysis. Rash is typically maculopapular, with target lesions being characteristic, may develop into vesicles or bulla. Mucosal involvement is present, and systemic symptoms like fever and arthralgia is present. Causes of Stevens-Johnson syndrome and TEN: penicillins, sulfonamides, lamotrigine, carbamazepine, phenytoin, allopurinol, NSAIDs, and oral contraceptive pill. Stevens-Johnson syndrome, or toxic epidermal necrolysis. The rash in SJS-TEN consists of painful pink to dark red spots that may blister and usually involves the skin, lips, mouth, eyes, and genitals. In early stage rashes, we can see flat or slightly raised pink spots with dark red centers, and in middle stage rash, we can see blistering and peeling skin. Typically, rash distribution is on trunk and upper shoulders of the patient. Redness, blisters, and erosions of the lips and inside of the mouth is very common, and redness, irritation, pain, and erosions of the eyelids and eye is also common. Management of TEN or SJS. It's emergency and requires hospitalization, often in ICU or burn units. Stop the offering drug immediately. Sportive care is the cornerstone. Fluid and electrolyte balance is important. Nutritional support, wound care, non-adhesive dressings is important, and pain control is very important for the patient. Infection prevention is also must be considered. Adjunctive therapies like systemic corticosteroids, early use in some cases, and IVIG is the mainstay of management. Cyclosporins or biologics also can be useful. And ophthalmology referral is critical for eye involvement in patients with toxic epidermal necrolysis or Stevens-Johnson syndrome. Okay, this was a short explanation about toxic epidermal necrolysis and Stevens-Johnson syndrome, the causes and presentation. Thank you for your attention.